Okay, so let's get straight into this, Simon. Here we go. Hi, I'm Tyson Franklin, and welcome to this week's episode of the Podiatry Legends podcast designed to help you feel, see, and think differently about the podiatry profession. With me today is another repeat offender. It's Simon Bartold. Every time he puts his hand up and says, "Oh, I've got something to say," I go, "Oh, come back onto the show and let's talk about it." So today we're going to talk about what you don't know about the growing athlete. So Simon, good to have you back on here.
Thanks, Tyson. Sorry, everybody. I'm sorry you have to keep on hearing my voice, but we'll try to give you something interesting today.
Well, if every time you're on, the download numbers are pretty good. So that's what I said. When you put your hand up and say, "Hey, I have something to say," I want to hear it, and so does everybody else. So this subject about what we don't know about the growing athlete, what do you mean by that?
Well, I think there's a bit of an assumption that we, as podiatrists, physios, whoever we're talking to, I think there's an assumption that we have a complete handle on how we deal with these conditions, especially the osteochondroses, Tyson. So things like, the ubiquitous Seaver's disease and Osgood-Schlatter's, and there are about 7 or 8 really important ones. And I think most people feel, yeah, I know exactly what's going on there, but I reckon maybe that's not the case. So I think there's probably some very good new information, not only on their natural history and what they are, but also on how you manage them.
Yeah, so I learnt about these conditions back in the mid to late 80s.
Mm-hmm.
And then since then, yes, there's been the occasional conference you go to and somebody will talk about it, but there hasn't been a lot of new stuff that's come out recently. So is that where you've been putting your attention into?
Yeah, it has. As you know, we've just released a brand new course called the Osteochondroses, and we cover 7 conditions from the 2 important ones are the extensor mechanisms, so Osgood-Schlatter's disease and Sinding-Larsen and Johansson, and we go all the way down to an osteochondrosis of the hallucis sesamoid. So we cover all of those conditions, and it would be fair to say there's quite a bit has changed as recently as the last 12 months in the way we look at these conditions and the way we manage them.
In what way?
Well, I think there's a lot of conjecture. Let me give you an example. So with Osgood-Schlatter's disease, I think most people would consider this. It's very common. We all see it, characterized by pain over the tibial tubercle where the patellar tendon inserts into the tibia. Everybody's familiar with that. We know that it might be associated with a growth spurt. What you may not know is that the growing athlete, there is a transient deficit in bone mineralization. In other words, we have around about 15, we have a period of time where we have reduced bone mineralization. So if you like, a transient form of osteoporosis in a growing athlete. Now, did you know that?
No.
So what that means is that there is a window of opportunity for these injuries in the growing athlete that perhaps people didn't understand. And that certainly is the case in Osgood-Schlatter's disease. But
you were mentioning, we were talking last week about this, and you said even the age of how long this condition can go for is much longer than what we were taught originally.
Well, this is exactly it, and this is a dogma that we've been led down a particular path, and this is unfortunately something we pass on to our patients, and we say, well, Osgood-Schlatter's disease, it's a self-limiting condition, as we would say the same thing with perhaps calcaneal epiphysitis or Seaver's disease.
Yeah,
it's self-limiting. Once the growth plate is closed, there is no potential for injury, and I'm here to tell you that that simply is not the case. And in Osgood-Schlatter's disease, the age range is defined from 10 to 45. And there are at least 2 good studies that tell us that about 60% of all people will have pain over the site of Osgood-Schlatter's disease for up to 9 years after the diagnosis. So it can go on well into adulthood. And of course, this is quite important because you see somebody with anterior knee pain and they're in their late 20s or 30s, you're not typically going to make the diagnosis of Osgood-Schlatter's disease, are you?
No, and that was something that I mentioned to you about my wife. She had that problem when she was younger, and I remember her talking about it. And when she was probably in around 40, all of a sudden she was having problems in that area again. And she said, wow, this reminds me of when I was a kid. I had this and she says, it feels exactly the same. It's everything that certain things that I do, exacerbate it the same way it used to. And my original thought was, well, it's not that.
Yeah.
But after talking to you,
it almost certainly was that.
yeah. And she had a problem with it from probably about 40 up until about 45. And then it went away from that point onwards.
Yeah. So you can understand that it's quite important to get a handle on these sorts of things. And the same may well be true of calcaneal epiphysitis, because it's very important in terms of actually making the diagnosis when you see a more mature person. And it's also very important in terms of how you manage the athlete. So I think that when we see it in kids, and typically we see this start, between 13 to 15 in girls and maybe a little bit later in boys. But it's very important. The education side of it is super important. And we go into this in a lot of depth in the course, and we talk about management options for this condition, and particularly moving away from this dogma of saying it will go away when the growth plate closes. For some people that is true, but for better than half, that's not the case. So we have to be very cognizant of the fact that it may well keep on going, and we have to put strategies in place to make sure that we can control the pain, because you can't make it go away. Absolutely, that's not possible.
Yeah, well, that's what I was going to ask. So there is a percentage. You said about 50% of people, well after the growth plate closing, still can have ongoing symptoms
for years, many, many years. Yep. So it is a case of understanding the correct management strategies for this particular condition. So that's really important. And I think if we talk about some other things, we talked about this transient deficit in bone mineralization, which is very important to understand that, and understand there is this window for these conditions. And that is where you really have to have a very good handle on load management. But also things like Seaver's disease. I like to call it Seaver's disease, Tyson, because I'm a huge fan of history, and I know that this condition, or actually what you may also not know is that calcaneal epiphysitis was first described not by J.W. Seaver, who gives the disease its name, but it was described by a bloke by the name of Patrick Haglund, as in Haglund's deformity.
Oh, Mr. Haglund, yes.
He was the first man to actually identify it as epiphysitis of the calcaneus, of the secondary ossification center of the calcaneus. So that didn't happen until some time after Seaver described pain in the heel in overweight children. That was his description, and he wrote it up as that in 1912. But we now think of, I'm guessing that you've always thought of Seaver's disease as a traction injury. Would that be correct?
Along those lines, like I know there's a lot of things that you can do that will spark off the problem, but mostly around traction.
Yeah, so most people would look at it and say, yep, you have a growth spurt, your posterior group gets tight, your triceps sura gets tight, Achilles tendon pulls on the vulnerable calcaneal epiphysis, and I'm sure there's what a lot of people listening to this podcast tell their patients. And that's
but also I look at the traction and a slight rotational force as well.
Possibly, yeah. But I think also people talk about the impact. So you've got a double whammy there, and that's certainly the way I always used to talk about it. But all of that's changing quite rapidly.
Yeah, that's a good point. I like that you pointed out that that's exactly how you thought about it as well. So if anyone's listening to this now and they go, "Oh wow, am I not a smart podiatrist because that's what I thought?" Well, no, even Simon Bartold thought that.
Well, that's what we were taught. And it makes sense, doesn't it? Because we think of that, we see the typical demographic for this is children involved in jumping sports, to start to ramp up their training. Often see it pre-season when the grounds are quite hard. So you've got the effective impact plus growth spurt, Achilles tendon pulling on the growth plate, bingo, there's your problem. But in fact, what we now know is that there's probably a larger contribution to this injury from compression rather than traction. And this is right in line with how we think about injury to the Achilles tendon. So Achilles tendinopathy is probably much more involved with compression of the Achilles tendon on the posterior facet of the calcaneus rather than a traction injury. And we think this is also what's happening in the calcaneus, that the Achilles tendon is compressing that fragment of the calcaneus between the epiphysis and the main body of the bone. So again, it feeds through to rightio. Well, that's completely different to what I got taught. How do we manage it? And we talk about this in depth in the course. We talk about strapping protocols, how you might change the way you think about orthotic therapy, load management, all those sorts of things. So it really is flipping the whole thing on its head a bit to keep in line with the current research and current thinking.
That actually explains my current Achilles problem. It's more of a compression, because at kickboxing, when you go to kick, you go up on the ball of your foot and you're spinning and rotating at the same time. You're actually compressing the Achilles, you're not stretching it.
No, that's exactly right. I think the current thought process is the vast majority of mid-substance Achilles tendinopathy is a compression injury rather than a tension injury.
So what made you decide to head down this track? So you said that you were taught a certain way, you had the same belief as the rest of us. What made you decide, hang on, I want to dig into this deeper? Was there something, was it a patient? Was it somebody else you spoke to at a conference? Something had to have
well, basically, I spend a lot of time mining all the current research. So I spend a lot of time on the University of Melbourne website Scopus, looking at all the papers that come through, like literally every morning. I have this feed that comes through. And I'd come across several papers that were talking about, in particular, thought processes on Osgood Schlatters and also on calcaneal epiphysitis. And I'm thinking, gee, this is really changing the way we think about this. And I don't reckon my peers are probably getting this information the way they should. I mean, I didn't know that there was also an adult form of Freiberg's infraction. I thought it was a true osteochondritis.
Yeah.
Of mainly the head of the second metatarsal, although it can be any of the metatarsals. But you can get an adult version of this. So it's a version that is dormant all through adolescence and early adulthood, and it doesn't appear until you're in your late 20s, and it's Freiberg's infraction. Now, I didn't know that.
And what sparks that off compared to having someone who's an adolescent?
It's usually sparked off by a change in activity or occupation. So basically, it's very weird. So it doesn't manifest all through those growing years, but it's actually happened. So obviously, the difference between, we could also talk about the difference between the osteochondroses and an osteochondrosis. But I think Freiberg's is a true osteochondrosis because we get changes to the bone below the cartilage, and everybody knows you get the flattening of the met head, and it has significant consequences later on because the joint is changed permanently. And so you can have issues there.
So is it when you may have an older patient, you do an x-ray of the foot, you notice the flattening of the head, and you'll ask them, oh, did you have this problem when you were younger? And they go, no.
Yeah, exactly.
I had no problems when I was younger.
Yep.
You go, oh, okay. Is this an anomaly to what I was expecting?
Exactly. And the interesting thing about all these conditions, and the reason I'm quite interested in the osteochondroses, is that they can be part of a very murky diagnosis. So you can imagine that if somebody comes to see you in their early 20s with pain around their second metatarsal head, you're thinking, is it a neuroma? Is it a plantar plate tear? Is it second MPJ joint capsulitis? What is it? And it's the same with Iserlin's disease, which affects obviously the base of the fifth metatarsal. It could be, you have to define it from a Jones fracture. You have to define it from a stress fracture or a diaphyseal fracture. So there's a lot of things can go on in these areas. And what we go to great lengths to point out in the course is when you should not be investigating. For example, a lot of these things are a clinical diagnosis, Seaver's disease, for example. But Freiberg's disease, you are compelled to x-ray it because you need to know what's going on at that met head and that joint. It's the same with Iserlin's disease. If that's what you suspect, you have to take an X-ray to define it, and you also have to take the correct history, because the osteochondroses are all overuse injuries. They're not traumatic injuries. They're not the result of a blow or an ankle sprain. Ankle sprain results in avulsion fracture, basically, in kids. So all of these conditions are basically overuse injuries. So if you've got somebody who's come in and said, I whacked it, or somebody trod on it, or yada, 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 you're almost certainly not dealing with an osteochondrosis. You're dealing with a traumatic injury.
So is that digging deeper into your questioning too with the patient and not jumping to conclusions?
Look, I'm a massive fan of history taking, and I think history taking by far is the thing that sets a good clinician apart from an ordinary clinician. I mean, if you can take a good history, you're way ahead of the curve, and I think that's something that we're probably taught poorly in university. There's not enough emphasis on this. I mean, if you want a really great experience, go and spend time with a medical specialist physician. There is no question they won't ask. There's no stone they won't turn to get the answer. Their job as a medical specialist is to make the diagnosis. That's what they do.
I remember going through university, Alan Crawford, who was the head of the podiatry department at the time, and him and I banged heads a fair few times, as you'd expect. But one thing that he said to me he said a few things to me that really, I don't know, set me up well for my career. And he said, if you ask the patient enough questions and keep asking questions, they will tell you everything you need to know. Yep. The problem is a lot of podiatrists will ask 2 or 3 questions, jump to a conclusion, put on blinkers, and they head down that path. Where he said, when you think you know what the answer is, keep asking more questions just to try and confirm what you already believe, or try and ask questions that are probably going to conflict with what you're thinking.
Yeah, I think
really well.
Yeah, that's good advice. I think there are two big mistakes that we make when we get the patient in and start going through this process. The first one is we don't let them tell the story in their own words. We kind of lead the jury, and I think it's very, very important to listen very closely to what they're telling you, because if you don't listen, you'll miss it. And the second thing I think we do poorly is we don't make the features fit. So we have our own little preconception of what it's going to be. Somebody comes in and says, I'll give you a great example. I had a patient years ago who came in. She was 11 years old. She had Seaver's disease. She had calcaneal epiphyseal. Everything was there. The only thing that didn't fit is that she was feeling a bit crook. And the other thing that was a bit unusual is that she'd recently arrived as an immigrant from Sri Lanka. Now, because I'm a suspicious bugger, I was just slightly concerned that I didn't know what was going on, because she's a bit unwell.
Yeah.
So I got one of my medical colleagues involved. And as it turns out, she had an isolated focus of TB in her calcaneus, and that was the diagnosis.
Oh, right. Okay.
So you never in your lifetime will see that, Tyson, and I'll never see it again. But that was the diagnosis, and that was the cause of her pain.
Yeah.
So the moral of the story is you got to have your clinical radar going all the time. And if you allow the patient to tell the story, and if you listen carefully, and the red flag pops up, do not ignore the red flag. Do so at peril.
In the 12-week reboot, just finished doing week 6 last week, and one of the things I spoke about was confirmation bias. And it's just where you already have a certain belief about something. So therefore you'll exclude all the evidence that goes against your belief, and you'll only look at what confirms what you already believe. And that's a really big mistake to make. It's got to not fall into confirmation bias. I had a patient who saw me many years ago, heel pain. I'm doing this really long history with him. And all of a sudden I've gone, okay, so you've used multiple types of footwear, no difference. You've seen a number of different practitioners, medical, physio, podiatrists. You've had 3 or 4 pairs of orthotics made. Everything I could possibly think of that had been done, not one bit of change in his heel pain. I said, so when you got an x-ray done? He said, oh, no one's ever done an x-ray. I went, oh, well, let's get an x-ray done. Did that, came back and hit a 4-centimeter tumor in his calcaneus.
Yeah.
And it was benign, got it operated on, pain went away and everything was fine. But he just said, I can't believe nobody. And I said, well, everything you were telling me, it was hurting lying in bed, hurting when you got up, hurting when you did activity, hurting when you just did nothing. In the pool, it hurt. Everything, It was just constant pain. I said, well, this is not fitting all the things that they've actually been treating you for.
Yeah. Yep. So great Jeff Matlin quote, make the features fit. And I think, for anybody listening to this, you've just said something really important. That is, if anybody has pain through the night, you should assume a tumor until otherwise proven. It's one of the cardinal signs of neoplasm.
Yeah. I always say when I'm at the GP or something, I always say, I want you to expect the worst. And then until we find out that it's not. And I used to say to the patients, okay, let's pretend it's the worst possible thing, and let's try and rule that out, and then we can sort of narrow it down from there.
Yeah, look, and I think it's an important point you make. I mean, the confirmation bias, we've just been talking about calcaneal epiphysitis. We assume it's due to impact and due to traction, but it's not. It's due to a number of other things, most likely compression. So we have to move on from the dogma and what we've been taught. We have to embrace the evidence and And I see that as part of my job. And one of the reasons I wrote this course is just to try to bring the most current information in front of us all, so that we can educate our patients properly, we can treat them properly, and we get a better outcome. That's what we're all after.
So with the course, how much is the course to do?
Well, the course is $199, but we've only just released it, so we've got an introduction offer of $99, so it's pretty cheap. But it's even better, Tyson, because this is the end of financial year, and as of today, it is $99, but you get a copy of my book, The Foot and Leg in Sport, all 800 pages of it.
I was about to say, it's about 2,000 words, 2,000 pages.
It's massive. It's been called the Bruckner and Kahn of the foot and leg. So it's very, very comprehensive. And you also get a copy of my book, Athletic Footwear, the Comprehensive Guide, which is about 300 pages. So I hate talking in dollar terms, but you're getting about $600 worth of CPD for $99. So we reckon that's a pretty handy end of financial year deal for people who are wanting to get this thing in before the end of the year and also ramp up their CPD. The course itself I'm very proud of it. We've got really high quality studio produced videos. It's extremely comprehensive. It's completely current, so right up to date. Within the last few weeks, really, and it's very, very comprehensive across all of the osteochondroses.
Yeah, well, there will be a link in the show notes. So if people go to my website, tysonfranklin.com, go to the podcast section, look for episode 156, which is what this one will be. There will be a link there that you can find more information out and register. I just think it's one of those things, people are always talking about CPD and wanting to do more CPD, but I think I hate when people just do it because it needs to get done.
Yeah.
I have to do 20 hours, and therefore they do 20 hours, they feel they've ticked the box and they can just move on. Whereas I think you should be, what's something you don't know about or something you can be better at, and focus on that, learn a new skill.
Yeah, absolutely. I think this is not so much about, cramming in your CPD. It's about upskilling and creating a point of difference with your competitor. I mean, we're all here to try to make our businesses as good as we possibly can. And I think the thing that gives you the edge is your clinical acumen. And the only way you can get that is by continuing to learn. And you do that until the day you die, basically. I mean, one of the interesting things about our courses is these are not membership-based courses. You buy the course and you own it forever. So if you want to do the course over 3 years, you can. That's fine.
Okay, so there's no time limit. You can just
there's no time limit.
You've got it for life.
Got it for life, and as you go work your way through the course, we've got we keep track of the time you spend on it, and then once it's completed, you get your certificate with proof of the CPD you've done, which is roughly 30 hours worth. So it's quite a bit.
Yeah, I think it's a no-brainer, especially when we know that what we were taught and what you're now teaching in this course doesn't contradict everything we've done, but it adds to what we've already learned, because you need to have the grounding and foundation first.
Yeah, I think it's one of those really interesting things that I think, a lot of people, me included, before I did this, thought, I'm not sure I need to know a lot more about this, because I'm sure I know how to treat it properly, and I'm sure I know all about it.
Yeah.
Well, I can tell you don't, because I didn't. and I read this stuff every day. I can tell you I've been absolutely gobsmacked by what I didn't know about these conditions. And it really, you'll read it on a Saturday and you'll apply it on a Monday in the clinic. It really will make a difference to the way you treat people. So
yeah, well, that was what I was going to ask. So when people are doing a course, there's a lot of practical stuff in there that they can do the course and apply back into the clinic straight away. It's not just a whole pile of theory. There's actual application.
Oh, 100%. Yeah. So as I said, there's a lot of video-based lessons in there. So we got, all the examination stuff. So we talk about that. How do you examine? What are you seeing? What's it all about? We've got taping techniques. Typically, there are 7 conditions we discuss. Each of those is broken up into either 4 or 5 lessons per condition. And it goes through what is it. It talks about diagnosis and investigation. And then there's a whole section on management and what's changed. So how you might apply that on a Monday morning, which you see somebody who comes in with posterior heel pain.
Yeah. So when you were talking before about, say, Osgood, you said it can go up to like the age of 45.
Mm-hmm.
I mean, you're talking about Sever's or Sever's disease, whichever way you want to pronounce it. Did it go longer Was it like, even though you may have an age range, was there an extreme case of an age?
Yeah, it can, and it's really interesting because it gets back to the physiology, which I like history and I like physiology, so I'm a complete nerd. But one of the reasons, there's been a lot of debate about why these conditions occur, and we've got a much better understanding of this, because what actually happens when the secondary ossification center appears is that we get a complete switch around of the blood supply to that ossification center. So before that center appears, the supply to the bone is via the capillary channels on the periosteum of the bone. And then it has to switch to a medullary supply once the secondary ossification center occurs. And it seems these conditions occur when there's a failure of that switch. So the switch doesn't go on.
Okay.
So there's an interruption to the blood supply to the secondary ossification center. And this is why the osteochondroses occur. So, and we discuss all this, of course, as well. So it's particularly interesting because the question that has always been for me is, I'm the coach of the footy team. I've got 4 kids who've got Osteochindroses disease who are languishing in the back line and getting about 3 kicks a game. And I've got my on-ballers who are running around all day long and they never get Osteochindroses disease. It doesn't make any sense. So it's not activity related necessarily. There is something else happening here, and we think it's this unique physiological phenomenon that's a part of the equation here. So we're getting a much better understanding of what's going on with these conditions.
Yeah. So with when you're looking at different sports, did you find there was any correlation? There was an increase in certain problems in particular sports? Because I know when I was in the clinic, whenever a child came in with heel pain, soccer and hockey were 2 of the real big ones, where as soon as if a kid walked in and sat down and I'd say, let me guess, heel pain and you play soccer. And you go, oh, you're good, aren't you? And I go, yeah, I am. But, and somebody asked me once, well, how come we don't get any rugby league players in? And I know, could be thickheads. But I could say that because I used to play rugby league. So, but yeah, I used to find hockey and soccer were 2 of the biggest sports and very similar sports, whereas hockey is like soccer with sticks.
Yeah.
So, same sort of rules.
Yeah, for sure. We go through all of that on a condition by condition basis. So you're quite right when you see things like Osteochindroses disease and calcaneal epiphysitis, they're very much associated with jumping sports. So things like netball, basketball, field hockey, football and soccer. It's very, very endemic in Aussie rules as well. And it probably has a fair bit to do with the derelict design of the football boot as well. And then, of course, you see things like Freiberg's infraction. Beware of these conditions in the growing dancer. So endemic in dancers as well. So, and again, think about these as not traumatic conditions, but overuse injuries. So, but we go through that. So there is definitely the distribution by sport of the different osteochondroses is quite profound.
Okay, so what I'm hearing is if you work with a lot of children, you should be doing this course. If you treat a lot of athletes, you should be doing this course and not thinking that you already know everything.
Yeah, and I think that's fair. And look, I'm not telling people how to suck eggs here by any means. So, I'm trying to be respectful of what we know. I'm just here to tell you that I didn't know what I didn't know.
Yes,
I didn't know a lot. I didn't know a lot. So, and I think this is one of the things that we've sort of probably got ourselves into a comfort zone with the osteochondroses, because we do think we've got a handle on it, and a lot has changed in the last 12 months. So I do think it's an important course for people to take. I mean, at $99 to own it, it's really cheap, probably cheaper than anything else available on the internet. So it's, and of course now you get the bundle, so you get the books as well. So it's a terrific offer, and I think it's something that anybody who wants to elevate their clinical skills, it will be particularly useful for them.
Yeah, and it's probably one of those things too, because we have a lot of success treating patients with these problems when they're younger, where a child will come in and they can't play sport, and you can get the pain level down fairly quickly and get them back on the field, and they enjoy the season. They might come back the next year, and you might have to keep repeating a few things. So because we treat certain things successfully, like a high percentage, this is where we can just take it to a new level.
Yeah, maybe. I think a lot of people use the terms LTFU in their case notes. It stands for lost to follow up. So this is what can happen. So what can happen with these conditions is you manage them in the short term, and you get a short-term reduction in pain, and then it comes back.
Yeah.
And then the kid says, "This really sucks. I'm just not going to play sport anymore." And then
Well, I've heard that.
we have the whole snowball starts to roll. So we have all of the potential comorbidity and all the potential bad things that happen when you don't play sport. And this is particularly important for girls. I'm very passionate about educating parents and adolescent girls to make sure they play weight-bearing sport and they make a commitment to a lifetime sport, because it's so important in terms of building their bone bank and making sure they've got healthy bone into adulthood. If they don't do that, then there is the potential for a really big issue later on in life. So this whole thing of loss to follow-up and just getting jack of it because the pain comes back and you just can't be bothered. This is something that we have to be very aware of, and something we do talk about in the course, saying we've got to make sure that education is the key. You might need to say, listen, this might come back, and if it comes back, we have to make sure that we get on top of it again, because we don't want you to not be playing sport, because there are consequences to that.
Yeah, so a lot of young adults that used to come into the clinic with other problems, and you'd be talking about their sporting history. And so it's surprising how many of them did stop sport at a relatively younger age because they said, I just got sick of the pain.
Yep.
It was easy just not to do anything.
100%. Yep. 100%. There's a reason. We're pretty lucky in Australia, but we still 7% of children aged 1 to 18 in Australia are classified as obese. 7%. So we're approaching 1 in 10.
Yeah.
So there are reasons for this, and this is where physical activity is just so important, and playing sport is so important. There's so many social and psychological benefits to it as well. So looking at the growing athlete is much more than just focusing on injury. It's about trying to understand the implications of the physiology, the psychology of sport, the chronological aspect. So, is your child playing rugby league in the under 13s against a kid who's 6'2" and weighs 115 kilograms, which can happen?
Yes.
Incredibly intimidating. I mean, I personally have been in that situation. I was a little kid playing Australian rules football, and I was playing under 15s against kids who had a full beard. It's like
I do remember that too.
Yeah, yes. It's super intimidating, and you just stand there and hope you don't get a kick, because the kid's going to hit you. So there are a lot of things we need to think about in terms of the growing athlete.
No, I think this has been fantastic, Simon. And just to remind people, there will be a link in the show notes, so go and check that out. I just think for the $99 at the moment, to have that, like you said, you can register for it, have it for life, that you can keep going back to it. I just think it's going to make you a better podiatrist.
Yeah, look, I have to say that I'm pretty happy with the books too. I mean, the Foot and Leg in Sport in particular, it took me over 3 years to write full time. If you can think of a question to do with sports medicine or the foot and leg, it will be in that book. If you want to know what sort of collagen is involved in disease and repair, it is in the book. So it's a real reference text, and it's an absolute beauty. So you're getting that completely free, plus you're getting the athletic footwear comprehensive guide for free as well. So it is a pretty sweet deal.
So with your book, is it a hard copy or a?
No, they're both ebooks. Yeah, we figured that's the best way. Yeah.
I was about to say, you haven't got a bookshelf big enough to put an 800-page book in there.
No, it is a behemoth, the Foot and Leg in Sport. You don't want an 800-page book in your bookcase because it's too heavy.
Yeah, you have to reinforce it.
It's great for those patients who've got a ganglion. You can whack the ganglion with the book and it'll go away.
Yeah, well, you pick the book up and read it, and then you need to go to the physio to fix your back.
That's right.
Okay, so Simon, I want to thank you for coming back on the Podiatry Legends podcast and letting everyone know about the course, but also just talking about this. Even if somebody's listening to this and they go, no, I don't need to do the course. Well, you need to, but even if they say not to, I think just by listening to this is going to make them start thinking outside the box a little bit more, which is great.
That's my job. Yep. I always say I just want people to move outside their comfort zone and think outside the box and think about other possibilities, and just try to be as evidence-based as you can. But Tyson, thank you very much for inviting me back. I promise everybody you won't hear from me for at least 10 years now.
No, you'll be back. You'll be back at some stage. I think Jonathan Small holds the record. I think he's been on 6 times. So this is only your third time.
and he's got much better abs than me. I mean, every time I see you put those warriors up, he's number one, so he deserves the best abs. But boy, his body armor is very impressive.
Oh no, if you ever meet him, he looks just like that.
Yeah, I understand that. Yeah.
Okay, so I'm going to say thanks a lot, and I will talk to you again shortly.
Thanks, Tyson.